Good afternoon and welcome to Grand Rounds today. Today it's my pleasure to introduce Dr. Michael Kitchell. As many of you know, Dr. Kitchell wears several hats, but most germane to today's discussion and presentation is the fact that he's board certified in neurology and neurorehabilitation. The CME committee is quite pleased that he was able to accept our invitation today to provide us with a review of end-of-life care for patients with neurologic disease, and please virtually welcome Dr. Mike Kitchell. Thanks, Mike.
Thanks, Steve. For those of you in the audience who are actually primary care physicians, emergency department physicians, neurologists, or pain specialists, this actually is 1 hour of CME that helps to satisfy the requirement for us that we have 2 hours of CME every 5 years on end-of-life care. So I'll try to get through these slides. I'm going to be ambitious to try to get through the whole bunch in 45 minutes here, so we'll have some time for questions. So everybody knows we do have advanced care planning. Most people know we have Iowa physician orders for scope of treatment, or what's called IPOST. And then there's also a healthcare power of attorney. The IPOST has 4 main areas: CPR, yes, no, medical interventions, trying to describe what the loved one or the family might consider for interventions when the patient is hospitalized and may not be able to tell people what they want. Nutrition, obviously, tube feedings are a big question. I'll have more to talk about with that too. There's also medical decision-making. Is there a power of attorney, a spouse, or an adult child who can help make those decisions? And the nice thing about the iPost is that it's portable and can go with the patient wherever they happen to be. The problem, though, with advanced care plans are that sometimes they aren't available in a crisis, and about 25% of patients actually have an advanced care plan. They are often too vague, and then sometimes these are not even followed as the family doesn't really understand or agree with what their loved one put down. Now, for preparing for the future, it's really important to try to choose a surrogate decision maker. It's also important to clarify the patient's values over time. And then there's also a little bit of changes that happen as circumstances change too. And so it's important to go over, are there certain decisions that you would never change? And then it's important to inform the family and friends of one's wishes to prevent some conflicts. I'm sure many of you physicians know that sometimes different family members have different ideas too that can cause a clash. The role of the physician, though, in the advanced care plans is to initiate the discussion for goals of care, obviously review the written plans and make some more specific plans as their condition changes. And then sometimes it's to convert plans into orders and use those plans to guide the clinical decisions. There are certain models or systems, including one called Respecting Choices, and they outline 5 promises of the system for these advanced care plans. They say they will initiate the conversation, assist with advanced care planning, make sure those plans are clear, maintain and retrieve the plans, and then follow those plans. Another model is called 5 wishes, just like those are 5 promises. These 5 wishes are to be filled out by the patient, by the person, so that they will identify who they want to make those care decisions, the kind of treatment they want or don't want, how comfortable they want to be, because sometimes comfort trumps a lot of other issues too. How they want people to treat their loved one, and how they want their loved ones to know what their last wishes were. Now, it's always important in treating someone near the end of life to avoid care fragmentation. And in certain areas of the country, there's a lot more care fragmentation than there is here in Iowa, especially with our McFarland Clinic. I think we have a really good coordination of care, and that's the opposite of care fragmentation. It's a program where patients have fragmented care. They're often focused on the disease, not the individual. They fail to communicate from one setting to another. They don't update the plans, and then they force decisions into an either-or box, that is, treating the disease or focusing on comfort. So it's always better to have that care coordinated. Now, most people realize that in the last 2 years or 6 months of life, a lot of the healthcare spending goes for that end-of-life care, and some of it is actually rather futile. The actual average of days spent in the hospital for the last 2 years of life is about 16.7 days. The total cost of care nationally for those 2 years is about $69,000. And so that's a fairly expensive amount to spend when the patient is dying. When people were in the respecting choices system or model of care, their average was a total of 9.7 days over the last 2 years of life, and $47,000 was spent. The worst example is New York City, where they spent 32 days of their last 2 years in the hospital, and they spent $131,000. So again, there's this large variation from area to area in the country with how many days they spend in the hospital as opposed to being home or in hospice. And obviously the cost of care is tremendously variable as well. Now, most people know that palliative care is managing the needs of the patient for the best quality of life, controlling pain and other unpleasant symptoms. And as we know, palliative care is not always in the hospice setting, but we neurologists can also help with assisting in palliative care because of our knowledge of those neurologic diseases that can be treated in certain ways, and I'll talk more about that now. Cardio-Pulmonary Resuscitation, unfortunately, a minority of physicians knew the patients for their preference for CPR or not having CPR. And I don't think most people know this, but in demented patients, in those severely demented patients, the overall rate of success for CPR is dismal. It's 0 to 4%. And then in one study, when patients who were severely demented had a cardiac arrest, they had a 0% chance of success for the CPR. And most people do want to die at home, at least that's their wish, but in reality, about half of all Americans are still dying in hospitals. 25% are in long-term care in nursing homes, and then about 20% are dying at home or in a family member's home, and 5% in other sites. Most people who care for a neurologic patient near the end of life, most physicians understand that caregivers are really stressed. That's a lot of what a neurologist is treating for severely demented patients or patients with Parkinson's who are severely disabled. A lot of caregivers are very stressed out. And so the studies show that 43% are depressed, 34% of caregivers report that they do a large amount of caregiving, and about a third of them have lost most of their savings because of these chronic illnesses. And 29% of the caregivers have lost income because of their work. And then about 20% had a major life change because of their new role as a caregiver. This often happens in the children, especially the adult women who are caring for their parents late in life. Now, end-of-life care in neurology involves a lot of different diseases, and I'll go over some of these. They include ALS, Parkinson's disease, and dementias. And it's actually better to invite the spouse and the family at some point where they are not there for an acute problem, but it would be better to have a calm conversation about what should be done in the future as far as what they want for treatment and how to make sure that the caregiver doesn't have too much stress too. So it's important to validate and reflect the emotions that can occur in these end-of-life situations, and it's important to communicate empathy as well. So some of the advice when you talk to a patient or a family who is nearing the end of life, it's important to say, what are your goals? What do you want to do? And then a good way to comment when people express all kinds of lamentations or concerns about their emotions. One of the good things to say is, I wish things were different. Obviously, we can't cure these people, but we can at least express our thoughts that we wish things were different. And then some people want to know a lot about their condition, other families don't, so it's important to know exactly how much they want to learn about that. And then another comment to make with those patients is, if time becomes short, what is most important to you? Is it definitely comfort? Is it trying to treat the disease as much as they can? What is most important? And then it's always a good thing to ask, what are your worries? The caregivers may have some worries that they won't express unless you actually ask them about that. So the possible goals of care include, obviously, a longer life, symptom relief, time at home, the ability to travel, although I think with the COVID situation, that's gone down on the importance list. There is mental clarity, mobility, minimizing burdens on their loved ones, spiritual growth, and then dignity. So those palliative treatment options, which I'll talk a little bit more about now, include medications for pain relief, antidepressants, and anti-anxiety medications. A lot of patients who are demented or who have Parkinson's disease or Lewy body disease will suddenly have a delirium. That's an acute encephalopathy, sometimes called a metabolic encephalopathy, and that's often due to sepsis, or it's a patient who fell and broke their hip, and when they're in pain or they're post-operative, those narcotics then simply make them even more delirious. They can be agitated. It's very difficult to treat these patients for this delirium. There are no good options. Many physicians still use the antipsychotic drugs, but those have not been shown to be very effective, to be real honest, too. So patients who have amyotrophic lateral sclerosis do benefit from some respiratory support. They can have BiPAP or a CPAP that helps with their respiratory functioning too. Many people with Parkinson's disease have non-motor symptoms. That is, they either have dementia with hallucinations and delusions. They can have blood pressure problems that might lead to a fall, because some people have orthostatic hypotension. I'll talk a little bit more about PEG tubes, percutaneous gastrostomy tubes for dysphagia. We often give those to people who have dysphagia from an acute stroke, and most of those, fortunately, will recover. But also patients who have ALS, who have involvement of their bulbar musculature, they do have some benefit from a PEG tube, although that obviously means they don't have the enjoyment of the taste of their food. Patients with a disease called progressive supranuclear palsy, which is a Parkinsonian-like syndrome, they also can have some dysphagia, and they might also benefit from a PEG tube. I'll talk more about the use of PEG tubes in dementia patients. In some areas of the country, there are nursing homes where 90% of severely demented patients living in that nursing home actually have a PEG tube to feed them. And I'll talk a little bit more about the controversy about that. Obviously, social support is very important for the families and the caregivers too, for those patients with these end-of-life issues. Now, we occasionally see some major strokes, and these are often younger people too who have either a large middle cerebral and intercerebral artery distribution of an ischemic stroke or large hemorrhagic strokes who will continue to progress. And those stroke patients sometimes do benefit from a decompressive craniotomy to reduce the swelling and help them stay alive. The problem, though, with hemorrhagic stroke and the bleeding that could lead to herniation and death or swelling and death, those patients, the surgery to intervene for a hemorrhagic stroke has no benefit for the functional outcome of the patient, though it may save their lives, because it does keep them from herniating. But the long-term functional outcome of those patients who have a large hemorrhagic stroke, it does not lead to a better outcome. So even though patients are sent from the emergency department to a neurosurgeon because they have a large hemorrhagic stroke, the only benefit that they get is they might survive, but the functional outcome, as I said, is not going to be any different whether they have the blood drained or not, because again, the larger the hemorrhage, the more the functional damage occurs. So, talking about amyotrophic lateral sclerosis, obviously it can start in the extremities, but when patients with ALS have some speech and swallowing difficulty, that's when you need to start to consider using a PEG tube. And you do want to make the decision before their vital capacity is too bad, because when patients with ALS have respiratory failure, not much is going to benefit them. Sometimes patients with ALS who have some weakness also have some cramps in the muscles, and so baclofen or gabapentin can help those cramps. As I said earlier, ALS patients do benefit from some help with their ventilation, particularly at night. And the number of patients with ALS who have some respiratory failure, only 5% or less actually choose a tracheostomy and mechanical ventilation. We have had a couple of patients, though, here over the years that have been in the hospital with ALS who wanted to be on a ventilator. And I can tell you that is not what I would choose to do, but it does occasionally happen. Some other examples for end-of-life care, there are patients who have had a cardiac arrest or who have had a really bad bout of sepsis that left them with some hypotension, and they can have a hypoxic or a hypotensive encephalopathy. those are patients who may need end-of-life care. Some of these will end up in a nursing home, and the question is whether to put a feeding tube in, because they may have some long-term recovery, but it's always difficult to predict, and that's where a neurologist can help with the long-term outlook for some of these people with significant hypoxic or hypotensive encephalopathy. We often see patients with severe stroke that is not only a right hemiparesis, but is a global aphasia. And so those people have a poor prognosis. And we do have family members who choose to have the patient go to hospice rather than to rehab, especially if the prognosis is poor. And so those are people with major left hemisphere strokes, occasionally with right hemisphere strokes, but most right hemisphere strokes do not cause any aphasia. Head injuries, we don't have a lot of them here, but obviously there are a lot of patients who have major deficits from their head trauma, and their prognosis is always a little more in doubt than some of the patients with strokes or the hypotensive encephalopathy. Head injuries can have a recovery that over a long period of time may be better than some of those other cases. We obviously do have some CNS infections, some encephalitis cases that have a poor prognosis. Jakob-Creutzfeldt disease is a prion disease that has a very poor prognosis, and those people obviously need end-of-life care. Unfortunately, there are a lot of people who have a glioblastoma. That's a malignant brain tumor. That's a primary brain tumor. And those people can have some benefit from treatment. Some people are on steroids, too, for reducing edema with the glioblastomas. And so they may need those end-of-life care choices as well. And then the most common patients that I see who need end-of-life advice and care are the dementias, and we'll talk a little bit more about the dementias too. Other neuromuscular degenerations besides ALS are rare, but those can also be an issue. So these are the types of dementias that neurologists will see. Obviously, Alzheimer's disease is the most common, but I've been seeing a greater and greater number of patients with Lewy body dementia recently, and most people know that Robin Williams, he committed suicide after he had the diagnosis of Lewy body dementia. And then even Ted Turner, the billionaire, he was on television last Thanksgiving and said he was grateful that he had Lewy body dementia rather than Alzheimer's disease because the prognosis was better, but he was obviously misinformed about that. I don't know how Ted Turner is doing these days. But Lewy body dementia is not only a dementia, they have some Parkinsonian features. They are excessively sleepy during the day. They spend a lot of time sleeping. And they have fluctuations that Alzheimer's patients don't usually have. And then if a person with a dementia has a lot of hallucinations and delusions, Lewy body dementia is probably more common than Alzheimer's too. It's not that Alzheimer's patients don't have hallucinations or delusions, but Lewy body dementia patients obviously have a lot of problems with that. And that's why it's hard to treat their Parkinsonism, because if you give them a dopaminergic medication like levodopa or the dopamine agonists, you may just simply add more hallucinations and delusions as well as confusion. I also spend a lot of my time every day treating people with Parkinson's disease who have had the disease for 15 or 20 years. And the great majority of them, if they make it 15 to 20 years, unfortunately do have some dementia. And then they may actually have a Lewy body type of dementia, not just Parkinson's with dementia, but a Lewy body dementia too. We don't see as many vascular dementias these days because most people have good treatment of their hypertension, but people who have not had good treatment of their hypertension can have a vascular dementia. And those people often have incontinence and gait difficulties as well that do make it difficult for their caregivers to treat them. We do see some occasional patients with frontotemporal dementia. I have a man right now that I'm treating, and his wife is really stressed out because the person with the disease has a major personality change and has absolutely no idea of the stress that his wife is going through, and is obviously totally impulsive and goes into a rage. I'm just surprised that his wife is still able to keep him at home. I think she deserves an award for that. And then I think people have been growing more aware of the fact that some football players and boxers develop a chronic traumatic encephalopathy. And then you probably read about some of these young people who've had chronic traumatic encephalopathy too. So this might, again, be an end-of-life care issue. There's another disease called primary progressive aphasia. I'm probably taking care of 3 patients with primary progressive aphasia. These are people who, if you just saw them once, you'd say, well, they must have had a left hemisphere stroke because they're aphasic. They can't get the words out, yet they're not demented, at least early in the disease. Most people with primary progressive aphasia, though, after about 5 or 10 years, do develop a dementia, not just an inability to speak. So again, those people do need some help. Their caregivers do need a lot of advice. And so end-of-life issues are a problem for some of these too. And then, as I have said, sometimes infections lead people with a dementia. I've unfortunately had a number of patients too who've had a progressive dementia with difficulty with ambulation and functioning that were due to post-radiation damage. They had a medium-grade glioma and had radiation therapy that unfortunately gradually led to multiple small strokes and a stutter-step progressive downhill course with dementia and sometimes even hemiparesis or inability to walk. So post-radiation damage can sometimes lead to these other very disabling conditions. So dementia is not just a cognitive decline. Most of the people with Alzheimer's disease don't have a major personality change, but perhaps 10% do. And those people may need some additional medication besides the acetylcholinesterase inhibitors like Aricept and so on. They may actually need an antipsychotic drug just to keep them from being agitated. I do have nursing homes that basically beg for those antipsychotic drugs, even though there's a black box warning saying this is dangerous, patients can have cardiac rhythm disturbances and sudden death, and there's a black box warning for antipsychotic drugs for use in people with delirium or dementia. Obviously, dementia patients that don't have some insight into their problem, they might wander, they might need some door locks or alarms on their house so their loved one knows if they try to go outside in the middle of the night and freeze to death. So these are problems in end-of-life care for these dementia patients, and obviously, as I said, cause a lot of stress for their caregivers. So as I said, there are different dementia types, and the presentation, even in an Alzheimer's patient or Lewy body disease patient, is sometimes quite variable. If you look at those non-demented versus those age-matched demented patients, though, the demented patients were more expensive, even with everything else matched exactly the same. Those demented patients had different comorbidities, they tended to go to the doctor more often, or their caregiver took them to the doctor more often because of their dementia. So dementia is a very costly disease, even though it's not maybe number one on the diagnosis list, but it can add significantly to the cost of our care for these patients, especially in the last year or two of life. And then, as I said, the prognosis depends upon the diagnosis, the comorbidities, and the activity tolerance. I find that an age-matched Alzheimer's patient or an age-matched Parkinson's patient with dementia, the care and the caregiver stress is much greater for the Parkinsonian or the Lewy body dementia patient than the Alzheimer's patients. The Alzheimer's patients are generally wanderers, or they might get into something, but the Parkinson's patients or the Lewy body patients need a lot more physical assistance from their caregivers, and so it makes it much more difficult for them. I find I'm spending a lot more time with my Parkinson's patients with dementia than I am with my Alzheimer's disease patients with dementia. It's not that it's easy to take care of an Alzheimer's patient, but again, there are fewer things that the caregiver has to worry about. So prognosis depends, like I say, on a lot of things. And then I do warn my Parkinsonian patients that are down the road a few years, and the other demented patients like Alzheimer's patients or Lewy body disease patients, I warn the caregiver that if they have a fever, get it checked out. You don't want them to be delirious, because believe me, no family member wants to see their loved one having hallucinations, delusions, or agitation. And delirium, even in a patient with a mild dementia who is hospitalized with a metabolic encephalopathy causing the delirium, their long-term prognosis is that they will probably not get back to their baseline. So it's very important to treat their infection, their sepsis, their broken hip with care so that the delirium does not lead to further problems. So as I said, advanced dementia, there's a gradual decline. Apraxia, forgetting how to open up a door, is even sometimes common in some dementia cases. Caregiver stress and burnout is common. And then, as I said, wandering is a real problem for some of these Alzheimer's patients, and safety concerns. Every neurologist will tell you they have arguments with the family or the patient regarding they want to continue driving. And so what I really recommend for either primary care or neurologists to do is say, okay, I don't think you should be driving, but if you want to be evaluated by the DOT, here's where you go to get your driver's license checkup. And if they pass you, I'm okay with you driving, but I try not to get into an argument, because these families or the patient, they do not want to give up driving even when it's appropriate to do so. Now, in advanced dementia patients, apathy is about 50% of the cases. They tend to just sit there and watch TV all day like a bump on a wall, and so sometimes delusions and hallucinations, especially in Lewy body dementia patients, can be a problem too. And then the studies have shown that about 71% of severely demented patients actually die within 6 months, mostly in nursing homes. A lot of people don't realize that severe dementia is a very, very big red flag for dying of something else, either sepsis or some other problems. And obviously, a lot of these COVID deaths did occur in some of these severely demented patients. So what we recommend for the demented patients is alarms and barriers for wandering, just like you have door alarms that you can have for children. You can have door alarms anytime the door opens, the alarm goes off. You can get those to help the spouses of the people who are living at home who may be wandering in the middle of the night. The acetylcholinesterase inhibitors like Aricept and Exelon, Razidine, those are helpful. We do use memantine or Namenda for moderate dementias. They may or may not be helpful for early dementias. The memantine is not likely to be helpful for a severe dementia. We do use antidepressants for anxiety and mood problems, and then, as I said, antipsychotic drugs are dopamine blockers, and they are usually only given for the severe negative behavior, agitation, and potential violence. One thing, though, that I think is really pretty obvious, you've probably seen videos of police wrestling with a psychotic man, and the man died. Well, was it the police, or was it all that epinephrine and norepinephrine that was going through a system and caused cardiac stress and cardiac arrest? So you need to understand that when people are extremely agitated, especially older people, they can die. And so if you're going to give an antipsychotic drug to avoid those severe bouts of agitation, you are probably saving their lives rather than the black box warning that says don't use these antipsychotics for people who have an agitated dementia. Benzodiazepines like Ativan, those are sometimes helpful, but they should only be used for short-term reasons. And then people with Parkinson's and dementia, I always tell the physicians who are treating Parkinsonian patients, if they are having confusion and some hallucinations, the first thing you need to do is stop the artane or the cogentin. The next thing you stop are the dopamine agonists. And then sometimes we even need to stop the levodopa, because that dopaminergic activity or that anticholinergic activity makes people more forgetful, and it makes them more likely to have hallucinations or delusions. Rivastigmine, which is Exelon, may be a little bit better than Aricept or donepezil, but there's still some debate about that. Exelon is the only one that actually has a study, though. The rivastigmine has a study that showed that that is helpful for treating Parkinson's patients with dementia and some hallucinations. There's a new drug out now, too, called Nuplazid that is helpful for hallucinations in Parkinson's disease. Anyway, the poor prognosis, those signs that we look for in dementia, generally, people with Alzheimer's disease don't have mobility problems until very late in the disease. If someone with a dementia has some mobility problems early in the dementia, it's probably Lewy body disease. But as the years go by, people with severe dementias will have inability to walk, dress, or bathe themselves. And they do have some incontinence, not just stress incontinence. When the dementia gets really advanced, they lose their speech and their vocabulary gets worse. And then, as I said, they're much more susceptible in those severe dementia patients to sepsis, aspiration pneumonia, pressure sores, and congestive heart failure as well. So those things all can lead to a fairly sudden decline and death. There's often a significant weight loss. This happens in a lot of dementia patients, and even in Parkinson's patients. They will simply lose their appetite, and then they will continue to lose weight. And that's sometimes an excuse to put a PEG tube in, but as I'll talk about, that may not be what you want to do. So, as I was saying earlier, those severely demented patients were not always perceived as being close to death, but yet 71% of those died within 6 months. And then, as I said, some nursing homes around the country, either down south or in Washington, D.C., a lot of them have PEG tubes for feeding. Instead of the personnel at the nursing home feeding the patient with a spoon or a fork, they simply hang a bag and then walk away and let the PEG tube put the nutrition in. So like I say, the range is about 7% to 9% in Iowa, to some states where 90% of severely demented patients have PEG tubes for their dementia. Now, non-palliative care is common. Lab tests, giving IVs, that's always a question. Is that what the advanced care plan has? Is that what the families want for their loved one? But anyway, for those advanced dementia patients, again, a lot of them die in nursing homes, some in hospitals, and then some in hospice care. So let's talk about the feeding tubes. Like I told you earlier, PEG tubes, and this has been well studied, PEG tubes do not add to the quantity of life. There's a 59 versus a 60-day median survival for those who had PEG tubes and those who did not have PEG tubes. So again, there's absolutely no evidence that this is going to prolong their life. And is it prolonging quality of life? They can't taste the food, so is that quality too? So as I said, unfortunately, in some states, PEG tubes are frequently put in dementia patients. They'll hospitalize them, put the PEG tube in, send them home a couple days later. Talk about increasing the cost of health care. But unfortunately, Medicaid reimbursement in nursing homes pays for those, and that means that the staff at the nursing home don't have to use the spoon or the fork. They can just put up the bag and walk away. So that's why it's still done some places. End-of-life choices for infections, that's a big question, big concern. For those patients who are hospitalized with an infection, there's a 20% mortality for advanced dementia patients, and pneumonia has a worse inpatient survival than actually outpatient treatment for pneumonias. So again, it's a question, should they even be hospitalized or treated? There's been no improvement in survival for urinary tract infections and pneumonia with antibiotics, and inpatient procedures obviously are often painful. And then if the people are in palliative care, obviously, then inpatient care is not necessarily recommended. So as I was saying earlier, CPR is very unlikely to help any of these advanced dementia patients. For anybody who's age matched, that's 3 times less likely to succeed in these advanced dementia patients. And the nursing home survival rate for CPR is 0 to 4%. And only 0 to 3% of people who actually have been transferred from the nursing home to the hospital and then go back to the nursing home, only 0 to 3% actually go back to the nursing home. So CPR should only be done in the nursing home if specifically requested. In other words, everyone should be DNR unless the CPR is absolutely affirmed by the family. So hospitalization, as I said, often leads to delirium. When people are in their home, they're used to where the bathroom is, they're used to where the bedroom is, but if they get sick and they end up in the hospital, delirium all of a sudden is much more likely to pop up. And the most common admission is for infection or dyspnea. About 43% of the pneumonias will recur later. So even if you treat them in the hospital for pneumonia, it's likely to recur. It's 5 times greater risk. And then the mortality rates at 12 and 24 months for a mild dementia patient, it's a 33% mortality, 48% for those in different studies. And then in advanced dementia patients, those mortality rates, the ability to survive long term is very, very small. So what do we do with demented patients with severe dementia who have hip fractures? There's definitely worse outcome in those who are bedbound. It is clearly, there's a difference between people with dementia who have lack of mobility versus those who are still mobile. Those who are still mobile are still going to live longer than those who don't. And the 6-month mortality after a hip fracture is about 50 to 55% for those patients with dementia. And so it's a significant issue if people have a hip fracture. And that's why we obviously want people to avoid falling. Pain was often found to be undertreated, and then it's always a good thing to talk to the family about palliative and hospice care and to avoid those complications. So recapping here, neurologic disorders at the end of life need some expertise from neurologists to help with making good choices on those end of care choices. And then symptom management and palliative care should be tailored to the specific patient and their preferences. Living wills, advanced directives are sometimes inconsistent and vague, and so the iPost is a little more definitive, but it does need updating, and especially knowing that 93 to 95% don't want CPR, it's important to get that documented. And then most people feel that power of attorney for medical decisions is really the best way to go because, again, those advanced care plans, circumstances change, and there are always some other issues that come up. So, again, having a person with power of attorney for medical decisions is good. And then obviously we know that hospice is underutilized in dementia patients. Only 11% in a national study of advanced dementia patients were referred to hospice. So again, making decisions about end-of-life care, how long, what will my life be like, and then how likely is the prognosis of recovery for a stroke or some other issues too. And then preferences and goals of care are important. As I was saying earlier, caregivers, 43% have depression, and those demented patients with agitation, aggression, and wandering are going to cause their caregivers even more problems. The interventions need to take into account what the caregivers' needs are and what their wishes are, and good communication and coordination of care with other providers are really important. If you have, like I say, I don't think this happens much here at McFarland Clinic, but sometimes different providers will order different things, and then things are really messy. So end-of-life issues in patients with neurologic diseases are obviously pretty complex. And as I was saying, many treatments like the PEG tubes are not helpful. And then advanced decision-making is advised, and then getting someone to be the power of attorney for those individuals is important. And we need to respect their preferences and choices. And obviously palliative care and hospice choices are encouraged. So I do have a few minutes for answering any questions. So Tim, just let me know if any questions are coming in. Yeah, there's a question from the audience here.
Yeah, Mike, when you look at CPR and demented patients, is there a Montreal cognitive assessment code, that a number where you see that marked decline in recovery from CPR?
The question is whether a demented patient has a particular score on a mental status test that would help. David, I don't know that there is any definite correlation of the numbers, for example, on the MoCA test as to what their chances are. But again, the severe dementia patients clearly have a very lousy prognosis for CPR. So I think it's kind of a gray area. The lower their MoCA score, the less likely they will have benefit from the CPR.
So less than
Less than 10%, absolutely.
No, I mean-
The MoCA score less than 10? Yes, yeah, approximately. I would just say the lower the score, the higher the risk, or the less likely that CPR would be helpful. So again, it's just those patients with a severe dementia, they're, like I say, that's just a big red flag for either a pneumonia or sepsis or whatever. And we often see this, like I say, in Parkinsonian patients too, because they will be very immobile as their life goes on, and then they'll get pressure sores, they might get an infection from that, and then bladder infections are so common. So again, there's so many things that can lead to a cardiac arrest or CPR and being needed, but the worse the patient's functioning is, the higher the risk that the CPR will not be helpful. So. Okay, there is a question from the audience too. Is there a difference in the 55% mortality rate of demented patients with a hip fracture, whether it is repaired or not? Yeah, that's a good question. Some studies have actually shown that the people who didn't have those hip fractures repaired had no worse an outcome. But I think you're going to have to make that an individual question, because some people have a lot of pain with their hip fracture, and so you don't want to wait for too long, because if they're really in a lot of pain, obviously if they don't have their hip fracture repaired, they're not going to be ambulating, so they're going to be sitting, and then that's going to lead to potentially more pressure sores too. So again, I don't know that the studies have really shown that there's a dramatic reason to repair it or not. I think a lot of choices are made to repair the hip fracture. But as I said, there's still, even if it's repaired or it's not repaired, the mortality is still 50 to 55%. So it's just, again, near the end of life, hip fractures are more likely because patients will fall more easily, and then again, their long-term prognosis, not necessarily because of the hip fracture, it's just that that's an indication, it's a red flag again, of a frailty or lack of mobility, which is going to lead to more risk of an infection like a pneumonia. Okay, Tim, I don't think we have any other questions unless there's more from the audience here, but thanks for listening, and hopefully this will give you some help when you have another end-of-life issue. Thanks.